Hello all, welcome back to my channel. Today we are continuing with the MRCP Part 1 sample questions in the RCP website with detailed explanations for the answers. Question 41. A 50-year-old woman presented with 6-month history of diarrhea and weight loss of 5 kg. She described her stools as pale and bulky. She had a history of Raynaud's phenomenon. On examination, the skin over her fingers was shiny and tight. What is the most likely cause of her diarrhea? So as we see, there is diarrhea and loss of weight, and she had a history of Raynaud's as well as skin was shiny and tight. Skin shiny and tight makes you think of scleroderma, right, or systemic sclerosis, especially with Raynaud's. So that is your limited cutaneous systemic sclerosis or your CREST syndrome, where there is calcinosis, Raynaud's phenomenon, esophageal dysmotility, and telangiectasia and scleroderma. That's your CREST syndrome. And in CREST syndrome, there is one association with bacterial overgrowth. That is, scleroderma can have bacterial overgrowth. Okay, that is one association of this CREST syndrome. So C for calcinosis, Raynaud's esophageal dysfunction, sclerodactyly, or that is the tightening of skin and of fingers and hands, and telangiectasia. And here there was one question in this MRCP which asked what causes esophageal dysfunction in scleroderma. What is the exact mechanism of esophageal dysfunction? It is actually esophageal reflex. Okay, it is esophageal reflex. We only studied like esophageal dysmotility. It's actually acid reflux. So that was asked. So coming to this question, this is asking what is the cause of diarrhea. So as I told, CREST syndrome has association with bacterial overgrowth. Remember this. Okay, so this is bacterial overgrowth. The limited symptoms of scleroderma are referred to as the CREST. There is calcinosis, which is calcium deposits in the skin. Raynaud's phenomenon, where there is spasm of blood vessels and respond to cold or stress. Esophageal dysfunction, where there is acid reflux and decrease in motility. Sclerodactyly, where there is thickening and tightening of skin of fingers and hands. And telangiectasia, which is dilatation of capillaries, causing red marks on surface of skin. And there is also another question which they ask, what is the antibody associated with limited cutaneous systemic sclerosis? It is anti-centromere. Okay, anti-centromere. For all the systemic sclerosis, all of them is associated with anti-SCL, but limited cutaneous specifically associated with anti-centromere. Okay, so there is idiopathic pulmonary fibrosis, which is like a restricted defect. We'll look at the options. FeV1 by FVC ratio will remain the same, or it is even increased in your restrictive diseases. It's not reduced. Peak flow 50% of predicted value. Residual volume 1% of predicted value, total lung capacity 95% of predicted value. For idiopathic pulmonary fibrosis, all of this will be reduced, right? Residual volume, total lung capacity will be reduced because the lung, there is fibrosis, so the area which is participating in the air exchange is reduced. So those are not the option. Transfer factor for CO 50% of predicted value. Transfer factor means that it indicates the air exchange which will be reduced in pulmonary fibrosis. So that is the answer. Transfer factor for CO 50% of predicted value. Among the option given, it is the right answer. A 42-year-old man was found to have abdominal liver function test. He had an ulcerative colitis for 15 years and was in remission and was taking mesalazine. So here they are trying to connect liver function with ulcerative colitis. You know what is the connection with things? Ulcerative colitis can have primary sclerosing cholangitis. Ulcerative colitis is an association with primary sclerosing cholangitis. We'll see the investigations. Albumin is normal, bilirubin is normal, ALT is slightly elevated, AST is okay. ALP is elevated and GGT is elevated, likely to be a cholestasis like picture. This is primary sclerosing cholangitis, which has been associated with ulcerative colitis. Both ulcerative and Crohn's, but more associated with ulcerative colitis. Next question: a 65-year-old man presented with gradually worsening exertional angina and underwent percutaneous coronary intervention with a drug-eluting stent. He was advised to take clopidogrel in addition to aspirin, atenolol, and atorvastatin. What is the predominant mechanism by which clopidogrel inhibit platelet aggregation? Question from pharmacology: mechanism of action of clopidogrel. This was asked in this MRCP exam as well. So it is P2Y12 inhibitor or inhibit ADP, binding of ADP. So that is the answer. One of that you can choose. P2Y12 inhibitor, if it is there in the option, that is the answer. Or if it inhibits binding of ADP is in the answer, that is the answer. So here it inhibits binding of adenosine diphosphate or ADP. That is the answer. We'll look at the other option. It enhances effect of circulating antithrombin. No. It inhibits cyclooxygenase 1. No. That is the action of NS8. NSAIDs. Okay. It irreversibly bind to GP2B3A. No. Those are GP2B3A inhibitors, which is not clopidogrel. That is your other drugs like tirofiban, epifibatide, those drugs. Okay, and it prevents production of thromboxane into blood. Next question: a 45-year-old man presented with recurrent epistaxis. On examination, there was telangiectasias on his lips and his mouth. The diagnosis of hereditary hemorrhagic telangiectasia was made, and what is the likely mode of inheritance? Direct question: what is the inheritance pattern of hereditary hemorrhagic telangiectasia? You have to somehow remember autosomal dominant, autosomal recessive, X-linked dominant, X-linked recessive. And here, hemorrhagic telangiectasia, it is autosomal dominant. Okay. Autosomal dominant. It's also called Osler-Weber-Rendu syndrome. Hemorrhagic, hereditary hemorrhagic telangiectasia. It is autosomal dominant. Next question: a 50-year-old man presented 24-hour history of agitation, confusion, and suicidal thoughts. He had started VAD chemotherapy when Christian doctor used dexamethasone 4 days previously, following a diagnosis of multiple myeloma. What is the likely cause of his symptoms? So he started on some drugs. Now he's having agitation, confusion, and suicidal thought. So always look at the culprit in the drug. Okay. Look at the options. Adjustment disorder. Adjustment disorder is when a person is not able to comprehend that he has this disease or someone close to him has some disease, or he's not comprehending and understanding and accepting some bad event. That is adjustment disorder, not the case here. He's having this post his being started on chemotherapy. Okay. That means he would have been diagnosed with multiple myeloma a little bit previously, and then he started on drugs. And post-drug therapy is having the symptoms. So not likely adjustment disorder. We look at the other options. Confusion secondary to sepsis. There is nothing suggestive of sepsis. Corticosteroid psychosis could be, especially when somebody started on drug and there is some adverse event. Always think of culprit among the drug. Reactive depression, Winchester encephalopathy, no. So it is corticosteroid psychosis. Next question: a 45-year-old man presented with 1 month history of food drop. What features strongly suggest L5 radiculopathy over a common peroneal nerve palsy? So this peroneal nerve palsy, what will cause? It will also cause food drop. But what will be there in peroneal nerve palsy? there'll be the actions of common peroneal nerve includes your dorsiflexion, okay, uh, eversion. Inversion is not a function of your peroneal nerve, it's dorsiflexion and eversion. So when there is common peroneal nerve palsy, the dorsiflexion will be gone, so the leg will be in a foot drop position. Hmm? Uh, so look at the options. Complete paralysis of extensive hallucis longus, loss of sensation confined to the lower calf, positive tunnel sign lateral to the knee, weakness of ankle inversion, weakness of ankle inversion. So weakness of ankle inversion will be there in both L5 as well as peroneal, but weakness of ankle inversion is not a characteristic of peroneal nerve palsy. So this is the answer. Okay. So we'll see the cutaneous nerve in the legs. In the anterior side, here we have lateral cutaneous nerve, branch of subcostal nerve, the leg in the lateral aspect in the thigh, then lateral femoral cutaneous nerve, here it is L2, L3, lateral sural cutaneous nerve which is L5, S2, superficial fibular nerve L4, L5, and the lateral part of your foot is supplied by sural nerve again S1, S2, and here coming to the medial side of the leg, it is saphenous nerve L3, L4, and here in the thigh medial side it is L2, L3. Okay, so D12 from the lateral side to the medial side, you can remember like D2, D12, L2, L3. Here there is S1, here there is L4, L5, then again L3, L4, and L2, L3. Okay, on the posterior side also given. Try to have a picture of this dermatomal distribution in the simplest way possible in your head. There were questions around 3, 4, I think 5 questions in total for this MRCP from the distribution. They'd asked about C7, C8 root, they'd asked about S1, and it's always been a combination, and you have to localize. There is lots of like uh, ankle reflex with loss of sensation on the side of legs, and that comes to because ankle reflex is L5, S1, so it could be L5 or S1, but the dermatomal distribution gives you a correct idea of which nerve root. So they have asked some questions. A7, C8 root was there. They asked about C5, and nerves also, medial nerve, posterior trochleus nerve, and their in previous papers also had seen questions from common peroneal nerve palsy. So somehow you have to go through this nerve, peripheral nerve, dermatomal distribution, sensory distribution. When they are asked about the muscle used for plantar flexion, so there are some questions coming from anatomy. When you get time, at least go through the pictures and try to have a pictorial memory of these things. Next question, a 21-year-old man presented after a traumatic hemisection of his spinal cord at T10 level. What is the most likely presentation below the level of the lesion 2 months after the injury? So below the level of lesion, and it is hemisection. So traumatic hemisection of spinal cord. Hemisection means what? It's Brown's cord. So they are asking about Brown's cord syndrome. Brown's cord. What is the presentation? So you have to know a bit in the spinal cord anatomy. So you have your spinal cord. I'll do a rough diagram. Okay. That's right. Okay. And you have your anterior and dorsal. Okay, you have your white matter here and gray matter in the inside. Now you have to understand that this patient had hemisection. Hemisection means half of his spinal cord is gone. So what all will be affected? So you have to know what happens and where each of the tract crosses. So dorsal column crosses only at the medulla. So if the dorsal column is coming through this dorsal area, it's going up, okay? It's going up, only at the medulla do they cross. So when there is a lesion here, okay, if there is a left-sided lesion, ipsilaterally they lose the dorsal column sensation, which is touch, vibration, okay, and proprioception. What about your lateral spinothalamic tract, or the pain and temperature? Pain and temperature, they will have, they'll go one or two level from the spinal level itself. They cross and go to the other side, and they go, okay, either at the same level or one or two levels above they cross. So lateral spinothalamic tract, if there is a lesion on the left lateral spinothalamic tract, they actually carry pain and temperature sensation from the right side, because it already crosses at one or two levels above the spinal, at the spinal level itself. What about your motor? If it is coming from the cerebral cortex down, okay, and it is crossing at the medulla, the acquisition, the pyramidal acquisition, and then it supplies at the anterior horn cell. It comes and then it supplies. So again, when there is a lesion at the left side, ipsilaterally you will lose, because it has already closed at the pyramidal acquisition. So ipsilateral motor loss. So we'll look at the option contralateral gross wasting. No, you will actually have in a spinal cord the thing, you will have UMN sensation below the level, for below the level, and lemon palsy at the level. Okay, so wasting will be a sign of element palsy. It will not be there, even if it's there due to disuse atrophy and all. It happens at the ipsilateral side and not at 2 months after injury. Contralateral loss of pain and temperature sensation. For pain and temperature, I told you they cross at the level or one or two levels at the spinal level itself. So pain and temperature will be lost. Contralateral loss of proprioception. Proprioception will be ipsilateral loss. Contralateral upper motor neuron weakness. The pyramidal acquisition happens at the brain level, medulla level itself. So it will be again ipsilateral. Ipsilateral gross wasting. Now, 2 months after injury, wasting is not that widely seen. So here it is contralateral loss of pain and temperature sensation. You have to know the pathways and where do they cross. This is your dorsal column, facialis gracilis, medially, facialis cuneatus laterally, and the lumbar is more medial and your cervical is more lateral. It is crossing only at the medulla, lateral corticospinal tract, and lateral spinothalamic tract. Lateral corticospinal tract is your motor tract, which is crossing at the pyramidal acquisition and at the brain level itself, and it's coming down. So when there is a loss at the spinal level, it's ipsilateral motor loss, and wasting can happen only many months after, when there is a disuse atrophy. Lateral spinothalamic tract carries pain and temperature sensation. It crosses at the level or one or two levels above in the spinal cord itself. So it will carry fibers from the contralateral side. So contralateral loss of pain and temperature will be seen in a hemisection. It's called a Brown-Sequard syndrome. Next question: a healthy 19-year-old medical student was asked to perform a Valsalva maneuver, which is forced expiration against a closed glottis, for demonstration purpose in a physiology class. What is the most likely initial hemodynamic response? So when there is Valsalva maneuver, there is increased intrathoracic pressure. So what happens when there is increased intrathoracic pressure? The cardiac, the right-sided cardiac filling reduces. So let's see what are the options. Decreased JVP, decreased systolic BP, decreased venous return to the heart, increased cardiac output, increased pulse. So as I told, increased intrathoracic pressure, decreased venous return to the heart. Straightforward question. Next question, 47-year-old woman was being treated with lithium for bipolar affective disorder. On examination, BP was 168/104. What is the most appropriate antihypertensive drug for her? For NICE guidelines, tell that antihypertensive choice less than 55 years and more than 55 years. That's how their guidelines states. For less than 55 years, it's AC inhibitors, and for more than 55 years, it's C, calcium channel blocker. So less than 55 years, it's AC inhibitor, and more than 55 years, it's calcium channel blocker. And the next add-on for along with calcium channel blocker is a diuretic, or even if with AC inhibitor alone, if it is not controlled, you add on a diuretic, or you can add a combination of AC inhibitor, calcium channel, and diuretic. Even if it is then not controlled with all of these three, then you go and add on the beta blocker and alpha and all. Here it is 47-year-old, but there is a twist. They are asking lithium, so they are trying to ask which drug is having the least interaction with lithium. So if you're giving AC inhibitor, they are all acting at the renal level. They all will reduce the excretion of lithium, okay, and there can be lithium toxicity. Okay, so you have to choose a drug which has least interaction with lithium and which will not affect the levels of lithium. So that is your calcium channel blocker. So amlodipine is the choice here, despite being less than 55 years. Okay, so it is amlodipine. For less than 55 years, actually it is AC inhibitor, and more than 55 years calcium channel blocker. But here calcium channel is preferred because there is less interaction with lithium. Other drugs like even your diuretics, AC inhibitors, all will cause reduced excretion of lithium, and that can cause lithium toxicity. Next question, a large prospective trial of statin in patients with angina. 1,000 patients were treated with statin and 1,000 patients with placebo. A total of 150 patients taking the placebo experienced a cardiovascular event compared with 100 taking active drug. What is the number needed to treat to prevent one cardiovascular event? A question from statistics. You have to know a certain formulas and certain or you have to understand the concept. Okay, so number needed to prevent one cardiovascular event. What are they telling? They have taken 1,000 patients. For 1,000 they give statin. So there is a control group who received placebo, which is also 1,000. The treatment group is 1,000 with statin. A total of 150 patients taking placebo experienced a cardiovascular event compared with 100 taking active drug. So what is the difference between the two? It is 50. Okay. So among 1,000 patients, there is a difference of 50. So can you calculate among 100 patients, what will be the difference? It will be 5. You divide it by 10, right? Okay. So they are asking, so among 100 patients, there is a difference of 5. What does that mean? That there is reduction of a cardiovascular event by a number of 5. Okay. They are asking what is the number needed to treat to prevent one cardiovascular event. They are asking to make a difference of 1%. Okay, what is the number needed to treat? If you treat 100%, you can make a difference of 5, right? So if you need a difference of 1, you divide that by 5, right? 100 by 5, what does that make? 20. 20. And the actual, so 20, okay? And the actual formula for number needed to treat is equal to 1 by absolute risk reduction. Absolute risk reduction. Absolute risk reduction. And what is the absolute risk reduction here? Here, among 1,000 patients, there is 150 who received placebo who experienced a cardiovascular event, and 100 among the control group, statin treatment group, has experienced a cardiovascular event. So absolute risk reduction is 150 among 1,000 minus 100 among 1,000. Okay, 150 among 1,000 minus 100 among 1,000. That is 50 by 1,000. That is reciprocal of 50 by 1,000 will be your answer. That is 1,000 by 50. That is 20. Or even if you're applying your logic and trying to solve the question, among 1,000 there is a difference of 50. Among 100 there will be a difference of 5. So among 20 there will be a difference of 1. That is what they are asking. To make a difference of 1%, to say 1%, how many percent do you need to treat? Okay, that is number needed to treat. Next question, a 37-year-old woman with a history of depression was brought to hospital having been found in a state of collapse. She had written a suicide note and had an empty bottle of amitriptyline in her jacket. On examination, her pulse was 135 beats per minute and her BP was 105 over 50. Investigation showed serum potassium 4.5, bicarb 18, so there is acidosis, urea 8.5 and creatinine 110. So there is acidosis and she has taken amitriptyline. ECG shows sinus tachy, QRS duration 135, bursts of non-sustained VT. What is the most appropriate initial treatment? So in amitriptyline, the initial treatment is to reduce the acidosis and you give sodium bicarbonate. Okay, you give sodium bicarbonate. Next question, a 20-year-old man was found collapsed. On examination, he had a GCS of 6. His pulse was 60 beats per minute, his BP was 90 over 60, and his respiratory rate was 8 breaths per minute. His muscle tone was reduced, pupil was small but reacting, and his plantar responses were downgoing. What is the most likely cause of his representation? So you see, he had a low GCS, there is bradycardia, hypotension, there is respiratory depression, muscle tone is also reduced, pupil is also small. So pinpoint pupil with all the respiratory depression, your BP low, pulse is low. What is the likely cause? It's opioid poisoning, right? Dihydrocodeine, opioid toxicity. Next question. On removal of renal arterial clamp following a donor kidney transplantation, the surgeon noted changes suggestive of hyperacute rejection. Which immunoglobulin is most likely to be responsible? A fact-based question. It is IgG. Hyperacute rejection, it is IgG. Next question, a 25-year-old woman presented with increasingly severe headache and 2 generalized seizures 36 hours after normal vaginal delivery of her first baby at 40 weeks gestation. She had been treated with epidural analgesia during labor. On examination, her temperature was 37.6. She was drowsy, there was a mild left hemiparesis, and both plantar responses were extensor. What is the most likely diagnosis? It is post labor. She is having headache and seizure. Okay, she had been treated with epidural analgesia. There is mild left hemiparesis and both plantar responses were extensive. There is some kind of a stroke-like event. And in postpartum period, especially immediately after delivery, there is high risk for cerebral venous thrombosis. Okay, so it is venous sinus thrombosis. Bacterial meningitis, not likely. Her temperature is okay. She had no fever or no infection prior to the labor or anything. Eclampsia, no. Not given a history of hypertension or anything. Subarachnoid hemorrhage, no. Viral encephalitis, most likely in a postpartum period presenting in like a stroke-like event is your cerebral venous sinus thrombosis. Next question. A half-life of novel anti-obesity drug exhibiting first-order kinetics was calculated to be 4 hours. What percentage of the drug will be eliminated 20 hours after ingestion of a single dose? So first-order kinetics means every half-life 50% will be reduced. Okay. So this the half-life is 4 hours. So in the first 4 hours, the drug will be 50% of what was in the beginning. 50% would have been used up or eliminated. In the next 4 hours, another 50%. That is 50% of what is remaining. That is 25%. Another 4 hours, 50% of what is remaining, that is 50% of 25%, that is 12.5%. So in the first 4 hours 50%, next 4 hours 25%, next 4 hours 12.5%, next 4 hours 6.75%, next 4 hours 3. Um, the half of that, right? 3.125, right? So you total that much will be used up. That is 50 plus 25 makes it 75 plus 12.5, that is 80. 75 plus 12.5, that is 87.5 plus 6.25, 6.25, that is 87.5 plus 6.25, that is 93, 90, almost 93, 94%, plus 3, 97%. So 97% will be used up. So T half is 4 hours, 20 hours means 5 times T half. So 5 T half will be used. That is 50% will be used, then 50% of 50%, that is 25%, and half of that 12.5, 6.25, 3.125. You add on that, you'll get 97% will be eliminated. Next question. A 16-year-old boy with type 1 diabetes mellitus was treated with a biphasic insulin preparation, but achievement of good blood glucose proved difficult. He was offered treatment with the insulin analog insulin Lispro. What characteristic of insulin Lispro might improve his glycemic control? Options are low incidence of hypoglycemia, low incidence of lipoatrophy at the injection site, low risk of immunogenic reaction, rapid onset of action, and small injection volume. So it was initially given a biphasic insulin, now is giving insulin Lispro. And the characteristic of insulin Lispro is its rapid onset of action that can control his blood sugars. Next question. 74-year-old woman presented with distressing restlessness in her legs, particularly at night. She had usually had to get out of bed several times to reduce her symptoms, and her sleep was being disturbed. What is the most appropriate treatment? So this is restless leg syndrome. Restless leg syndrome, RLS, which can be treated with your Pinerol, that is a dopamine agonist, or you can give gabapentin or that class of drug. So here among the option, dropinerol is the answer. It is a dopamine agonist. Next question. A 32-year-old man was treated with combination chemotherapy for testicular cancer. Subsequent investigation confirmed a complete clinical remission. What is the dominant cellular process that explains why this therapy was successful? So given combination therapy, now is having complete clinical remission without any complication mentioned. Then that process would have been apoptosis. Apoptosis. Okay. Programmed cell death. Right? Apoptosis. Next question. Large multicentric clinical trial to assess effectiveness of new antihypertensive drugs. Subjects were randomized to be treated with either the new drug or an existing standard antihypertensive drug. So there is a control group, there is a treatment group. The main outcome criterion was the blood pressure after 2 months of treatment. The outcome criterion is blood pressure itself, not whether it is reduced or not. Yes or no question. It's not an yes or no question, it's actual value. What is the appropriate statistical technique to compare mean BP between two groups? So to compare mean between two groups, anything, mean BP or mean anything, mean between two groups, the test you use is, and if it is two group, you use two sample t-test. If it is more than 2 groups, you have to use other techniques, but for 2 groups you use two sample t-test. Chi-square test you use if it is a yes or no question, whether hypertension has reduced or not. For that kind of question, you can use a chi-square test. Otherwise, if it is mean between 2 groups, you use two sample t-test. This was asked in this time MRCP also. They asked to compare mean between 2 groups. Which of the test would you use? This is two sample t-test or a paired t-test, we call it. Next question, a 71-year-old woman present with 2-hour history of severe pain, loss of vision in her right eye. She had noticed halos around lights during the previous 24 hours. On examination, there was ciliary vessel hyperemia and a dilated unreactive pupil on the affected side. What is the most likely diagnosis? So, painful loss of vision. So, there is DDs for painful loss of vision and painless loss of vision. Painless loss of vision, usually your central retinal venous occlusion and central retinal arterial occlusion. Painful loss of vision can be, we'll look at the other options. There is halos and there is ciliary vessel hyperemia also. So that is your glaucoma, closed angle glaucoma, which can be painful, and also ciliary vessel hyperemia is one of the earliest signs of your closed angle glaucoma, and that is having also dilated unreactive pupil. So that is closed angle glaucoma. So glaucoma means high intraocular pressure. So normally the aqueous humor circulates in the eye, but when the drainage canal is blocked, it stays in the eye, and that increase the pressure inside the eye, which damages the blood vessels and the optic nerve, which generates progressive vision loss and blindness if not treated, and it is painful also. Next question, a 16-year-old boy presented 30 minutes after sustaining a head injury. His parents reported that he had fallen and hit the right side of his head on the ground. He had lost consciousness for a few seconds, then recovered fully. On examination, was fully conscious and had no focal neurological signs. 2 hours later, his conscious level deteriorated. What is the most likely diagnosis? So here, there is head injury. Then there was loss of consciousness. Then he recovered fully. Then after some time, he again deteriorated. So this in-between interval is called your lucid interval. Once you identify this in the question, the diagnosis is there. What is that? It is extradural hematoma or epidural hematoma, EDH, which is classically having this lucid interval. That is, patient is falling, they hit on the ground on the side where there is damage to the middle meningeal artery. That is the one that is bleeding in EDH. And then they bleed. They have a loss of consciousness briefly, which is followed by awakening, and then they deteriorate again. That is why in a head injury you have to admit the patient and observe them for at least 24 hours. Okay, and have a CT done. If there are indications like vomiting, loss of consciousness, seizures, or anything suggesting that you need a CT immediately, you have to have a CT to rule out bleed. Next question, a 55-year-old woman present with 2-day history of diplopia and progressive gait unsteadiness. On examination, she had limited eye movements in all directions and her pupils were poorly reacting. Muscle power and limbs were normal, but tendon reflexes were absent. There was prominent bilateral finger nose ataxia and plantar responses were flexes. Sensation was normal. What is the likely diagnosis? So we'll see what is happening here. There is diplopia. There is gait unsteadiness. Had limited eye movements in all directions, limited eye movements. Tendon reflexes were absent and sensation was normal. So tendon reflexes were absent means there is areflexia. Gait unsteadiness means ataxia. Diplopia and eye movement loss means ophthalmoplegia. So ataxia, areflexia, ophthalmoplegia, classical of your Miller-Fisher syndrome, which is a variant of GBS, where the sensations are intact, but there is ataxia, areflexia, and ophthalmoplegia. So 58-year-old man with congestive heart failure remained edematous despite treatment with furosemide 120 mg daily. Investigation is showing serum sodium is 134, a bit low, potassium is 3.4, serum urea is 10.6, creatinine is 156. What other finding is most likely? So we'll look at the options: high plasma aldosterone, high serum cortisol, low plasma angiotensin 2, low plasma atrial natriuretic peptide, and low plasma renin. In congestive heart failure, the atrial natriuretic peptide will be high and there is low sodium. So in response to that, aldosterone will be high. So it is high plasma aldosterone. So to have high aldosterone, we'll have high renin also. So that option is wrong. So atrial natriuretic peptide will be high, renin will be high, and your aldosterone will be high. Next question: a 34-year-old woman who was 14 weeks pregnant had a 6-year history of Sjogren. What antibody in this condition is most strongly associated with increased risk of congenital heart block? Direct question: it is anti-Ro, which is associated with congenital heart block. We'll have some similar naming antibodies. Anti-Jo is seen in polymyositis. Anti-Ro is having cardiac defects in neonatal lupus and this Sjogren. Anti-Yo is associated with paraneoplastic cerebellar syndrome. So that's all for today. Thank you. Follow for the upcoming videos. We'll have a session which is continuing with the sample questions, and we'll have more updates on MRCP part 1. Thank you so much and all the best for your exam.